Dr. Cooper, Andrea, you both know how popular our mailbag episodes are, right?
Yes.
Yep.
They're so popular. We have just been inundated with emails from those of you all over the world. And I'm guessing some of you are saying, I wrote 3 months ago. Where is my answer? How come Dr. Cooper hasn't read my email? Well, we've got a solution. I think you're going to love it. Dr. Cooper, tell us what the solution is.
I will. I'm so happy to have found a solution because I feel so badly for all the people that keep writing these wonderful questions and we just can't get to them all. So what we're going to be doing is a monthly live Zoom Q&A on Patreon. So it's going to be available to subscribers of our Patreon channel.
Oh, wow.
Yeah.
Andrea, you do that on Patreon for some other shows.
I do it for a bunch
Tell
of people.
us more about what
Yeah.
it's like.
You sign up for this one. You sign up, and Dr. Cooper will answer a bunch of questions live, and you're going to get a lot of answers and great comments, of course, from Mark, from you and me. And I think it's going to be a lot of fun, and you're going to get a lot of really extra content that I promise it'll be worth it.
And if you've never done Patreon before, it's basically a platform for creators where you can incrementally support shows that you love. So if you go to patreon.com/fatsciencepodcast, you can check out, we've got a couple of different levels. One of the levels starts with a newsletter and the monthly Zoom call. The second level, which is a little bit more per month, actually involves a monthly Zoom call with providers. But anyone can subscribe to that one as well because it's going to be really good information.
Much more in depth.
Much more in depth. And just go to the Patreon platform, sign up to support the show that you love, and benefit from all of the perks. I think you're going to like it.
Hi, it's Dr. Emily Cooper. Are you a healthcare professional who wants to expand your clinical expertise and your approach to treating obesity? Beginning November 7th, I'm offering a 3-part, 20-credit live virtual course through the Diabesity Institute. This course will focus on science-based insights into diagnosing and treating metabolic disorders. I've treated thousands of patients over the past 25 years. Our clinics recorded their outcomes in a comprehensive database, and I've learned a lot that I'd love to share with you. If you're looking for clarity, a greater diagnostic understanding, and effective treatment strategies, for more information and for the official credit statement, visit fatsciencepodcast.com and click on the provider course link at the top of the homepage. All right, now to the show. There is no diet or exercise program that leads to long-term weight loss in someone with obesity. There isn't. And so that means there has to be pharmacology. And, that might be shocking for people to hear this, but it's just like any medical condition. It isn't going to change by you trying to trick your body by burning more fuel with your exercise and eating less fuel intake, because your body, the underlying metabolic dysfunction is still there, but then your body develops another metabolic strategy of conserving energy to kind of adapt to what you're trying to do to it. So when people lose weight, their body doesn't need as much fuel to maintain that lower weight. But when they lose weight through a diet, the metabolism slows down beyond that because of the diet.
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hi.
Hello.
All right, this is another edition of Mailbag where we hear from listeners all over the world asking amazingly intelligent questions about their metabolism. Let's start out from Los Angeles. Erica wants to know, hello, Dr. Cooper, Andrea, Mark. I've been listening to your podcast since it was recommended in a Reddit thread. I'm so grateful for the knowledge and wisdom you shared about metabolism, fat, and weight loss. It's truly science that makes me feel better. I've been on Zepbound since March. I've had great success, due in part, I'm sure, to the advice I've gleaned from the podcast. Something I've been thinking about, though, is the possibility of losing weight without medication. Calorie deficit doesn't work long-term, and exercising doesn't work long-term. It seems like if a person wanted to lose any significant weight, it would be extremely difficult without medical intervention. So, our question is, how does a person lose weight in a safe and healthy way that lasts without the use of medication? It's kind of a tricky question, though, isn't it, Dr. Cooper, from Erica? But a good one.
Yep.
Well, it's a great question. And actually, it's funny that Erica, thank you so much for the message, because it actually is something that we've been hearing a lot of murmurs about from the audience. I think it's on a lot of people's mind because they listen and they say, well, Dr. Cooper always says what not to do, but doesn't say what to do or how we're supposed to lose weight. So I'm so thrilled that you put this in a question that enables us to like tackle this one. But this is the gazillion-dollar question, really, when you think about it. And I think just as a brief kind of historical background, I don't want to spend too much time on this, but briefly, how I came to see obesity as more of a physical sign of an underlying metabolic problem is that I tried so much with my patients many, many years ago. I mean, we're talking 25 years ago, diligently measuring their metabolism with a gas exchange system and writing big spreadsheets of eat this way, like mathematical equations to like that should produce the weight loss. And my patients were like incredibly dedicated because they were very excited to take a more scientific approach than what they had been doing. And as we did this, we did see that you could force the body to lose that weight in the short term, but then it came back. And sometimes it just like really came back with a vengeance. And this was in spite of the people continuing to do what they were doing. So as we measured their metabolism, we could see that it was actually decreasing. And so the metabolic rate decreases as you try to reduce your caloric intake. And that is something that gets in the way of long-term success using these diets and exercise strategies to burn more fuel and eat less. It just is a dead end because it gets to a point where you couldn't possibly eat less than you are eating or exercise more than you are eating, and you are regaining the weight in spite of that. And so after a while, I started, that's what really opened my eyes to it, and I started to look deeper for a deeper, more meaningful reason that this was happening and more meaningful solutions. And so if you think of obesity as a physical sign, like in medicine, there are signs and symptoms. Symptoms are things that are reported by patients of how they feel and stuff. Signs are things you physically see in a physical exam or so. So obesity is really a physical sign of an underlying metabolic disease. And so we think of now, people are calling obesity a disease. And people ask me, do you think obesity is a disease? And it's a tricky question because I think obesity is a physical sign of an underlying metabolic dysfunction, and the underlying metabolic dysfunction is the disease process. And not everybody has that physical sign. They may have metabolic problems and have different physical signs, or they may have multiple. So not to be too complicated, but just to set that up so that you understand what I'm about to say, which is there is no diet or exercise program that leads to long-term weight loss in someone with obesity. There isn't. And so that means there has to be pharmacology. And, that might be shocking for people to hear this, but it's just like any medical condition. It isn't going to change by you trying to trick your body by burning more fuel with your exercise and eating less fuel intake, because your body, the underlying metabolic dysfunction is still there, but then your body develops another metabolic strategy of conserving energy to kind of adapt to what you're trying to do to it. So when people lose weight, their body doesn't need as much fuel to maintain that lower weight. But when they lose weight through a diet, the metabolism slows down beyond that because of the diet. And so that facilitates this backlash. We call it diet backlash, where you'll regain the weight. And most studies show that the ending weight can end up to like 22% higher than it was before you did the diet. So not only can you regain a portion of the weight back, because there have been some people that have maintained some of the weight loss after that. I'm not saying that there isn't, but we're kind of not satisfied with that. We want to go further. We want to take this to where you don't have to be in that mode of for the rest of your life on a diet and, watching everything you eat, occupying like your brain. If you think of your brain, having like 85% of it focused on the calorie in, calorie out of everything you're doing, I mean, that is taking away the quality of your life. So what we want to do is get away from that altogether and instead use the pharmacology for what it's meant to be, to strengthen that metabolic function while you can fuel your body and do your physical activity and be healthier and not be as concerned. And so I don't think there should be concern about having to stay on medication long term because for a medical condition. Sure, there'll be some people that could taper off, but I think going into it, you have to kind of be thinking that it's not guaranteed you're going to be in that group.
And I think, we've said many times on this podcast that fat is not a failure. I'd like to add something to that and say medication is not a failure. I talk to so many people who feel like they're failing if they have to take a blood pressure med or failing if they have to take a statin or something like that. And gosh, I mean, these drugs were made for a reason and they can literally add years to your life. I'm getting to the age now where I have friends who've had strokes. I've had friends who've had heart attacks. And if you treat this stuff properly, so much of that is preventable, isn't it, Dr. Cooper?
Yeah, I mean, so much is preventable. And that's why it's kind of so exciting because, these causes of preventable disease, now we have good pharmacology that can address that. I mean, I do want to say that the lifestyle strategies are important, though. So I'm not poo-pooing, like focusing at all on lifestyle.
Yeah,
because
big pharma plus Coke and Twinkies, you'll be fine.
Yeah, that's great. But I always say, like, why do you care if you're on medicine if your life is going to be better?
Yeah.
And like, if you're doing the right things, having the, like eating well, doing the right things, and taking a drug that's going to make your life better, why is that a problem? Like,
Yeah.
why is that an issue for you?
It's
Like,
society's pressure.
I don't get it though. I don't get it. It's like if you would take a pill that's going to get rid of your cancer and keep the cancer away, like, is that a bad thing?
Yeah.
If you were going to take a blood pressure like, why is that a stigma? Like, I don't get it. Like, this is helping your life be great and helping with a disease. Like, I don't see a problem.
There are people that really don't tolerate the meds either, and they don't want to have
then
surgery.
I get, yes.
And they don't want to have surgery, and so they are looking for the answer to this question too.
Yeah,
so
I
get
get
it.
that. Oh, you're right. You're
But
right.
one thing to think about too that we've talked about, weight and health are not the same. And so you could be really healthy at a high weight. You could be really unhealthy at a normal weight.
Yes, we
So-
know those people.
Right. And so the kind of thing is there is some level of how you feel in your body. Like, so say you have great numbers for everything and just you happen to have this high weight and you really don't want to use the pharmacology, don't use it.
Don't.
I mean, there's no reason to. But and no one should pressure you to do that at all. But lifestyle strategies do help keep our metabolism healthier. And it's just that they don't have the power to reverse obesity. That's what I'm saying. So they're an important component of our health for everyone, regardless of body size. And our metabolism does a lot besides regulate our weight. And so, eating, as we've described, like eating regularly on a consistent schedule that helps
Good
keep
things.
your circadian rhythm healthy.
Right, not Twinkies and Coke.
Well, we don't want to, the thing is just to focus on what you really should be getting in, which is, of course, foods that are loaded with food additives and artificial ingredients and things like that and highly processed. If you can avoid it, just eat regular food and all the food groups. Don't cut out things, just because it's a starch or something. Eat regularly throughout the day to fuel your day. Get enough of all of the macronutrients. It's proteins, fats, and carbs. Get your fruits and vegetables. Get your plant fats and your plant proteins.
As natural as the way it came out
Yeah.
of the ground as possible.
But, be flexible. Eat, it's better to eat something.
Oh, yeah.
If you can't get the perfect food, I mean, eat what's available. And your body can handle that. It doesn't have to have all pure, perfect food all the time. But, and same thing with not everyone has to eat like a plant-based diet, or not everyone
No.
has. So it's kind of like just
Be happy.
eat in a healthy way throughout the day, fuel your exercise, get adequate sleep because sleep is so critical.
Oh my
And
God.
physical
Yes.
activity is important, but you want to fuel it well. Managing stress is really important for metabolism too. So we have done episodes where we've talked about those lifestyle strategies in depth, but I don't want people to walk away thinking that that is really going to be powerful enough to reverse obesity, because it is not. That is a physical sign of a metabolic disease process. So that requires medical treatment with pharmacology.
Yeah. Can't
That's
do it
just the
on
way
its
it
own.
is.
Yeah.
And it's highly genetic.
Yeah.
Oh, yeah.
I can attest to that.
Yeah.
I've had the test to prove it.
All right. That was from Erica. Thanks so much for a great question, Andrea.
Okay, my letter is from Joanne from New Jersey. I have family in New Jersey. So she says, big fan of the show. Like many others, I've been overweight or obese since childhood. Welcome to the club. I had gastric bypass surgery 15 years ago, but never reached a normal weight. I subsequently developed reactive hypoglycemia, no high glucose or prediabetes. I started Zepbound in March of this year and have been doing great on it. I also asked my physician to prescribe a CGM so I could monitor my glucose. I guess that's a monitor. I'm learning to eat in a way that avoids hypoglycemic episodes. However, these episodes still sometimes happen, especially at night. My doctor said if this continues, he will have to decrease my dose of the Zepbound. All of the literature I've read points to GLP-1s helping with reactive hypoglycemia, not causing it. What's your educated opinion on this? And should I consider anything else for the reactive hypoglycemia? Thank you, Joanne.
Hi, Joanne. Thanks for this message. This is actually like one of my special interests. so I love this. I became super interested in this condition many years ago. I guess, let's see. I like to figure out how many years it was. Probably 15. When I was just inundated with patients who had the same thing going on that you're describing. And it was severe. It was affecting them to the point where they couldn't drive. They couldn't. One of my patients was terrified because she was going to get married, and she was afraid to that walking down the aisle, she was going to get a hypoglycemic episode or something. And so we had all this testing going on at the time to try to figure it out. I talked to all of these researchers throughout the country to try to figure out, our local endocrinologists trying to brainstorm about it, and came up with a really good strategy for this. And we have lots of patients who have done super well with this condition.
Can you define it first of all, Dr. Cooper? What is reactive hypoglycemia?
That's great. Yeah, it's weird. It's like everybody thinks, well, your blood sugar can drop if you don't eat. And so then you get hangry and stuff. But this is different. This is where it drops after you eat. It drops in response to eating. And some people will say, well, that's dumping syndrome. If you had the gastric bypass, there's something where, how the food leaves your remaining pouch there, that could trigger a feeling of low blood sugar. But this is different. This is different than dumping syndrome. And what it's usually due to is a spike in insulin that's abnormal right away. When food hits your mouth, the insulin from your pancreas is supposed to go up to match whatever the glucose is doing that's entering your bloodstream, so that your muscles can take up the fuel and that your blood sugar stays in a normal range. But this is a condition that tends, again, to run in families, where when food hits your mouth, the insulin on switch that turns the insulin production on is too overreactive, and it immediately turns on, and the insulin immediately. Instead of priming to get ready to produce, it just shoots right out. And that's before you've actually digested anything or it's even hit your bloodstream. So that ends up resulting in a very low blood sugar reaction, usually about 1 hour after eating. And it can be severe. It normally is not severe, but I'm just saying it can be. And it can be fatal too if it's extreme. And so it's very important to diagnose what's going on and figure out, is this due to one of those insulin spikes? The best test for it is called a mixed meal tolerance test, where you consume all the food groups as a regular meal, which you and Andrea do all the
Oh,
time.
our eating test.
Yes, your eating test. Yeah. And just the insulin and glucose should be measured at these 30-minute time points. 30, 60, 90 are the most important ones. You can go further if you want to, but it's mainly the 30, 60, 90. And it's the 30-minute one where you'll see these big insulin surges, and then it results in the 60-minute glucose dropping abnormally. So all of those glucose insulin ratios, it should be the insulin doesn't exceed 50% of the glucose at any time point. So if it is exceeding that, then that's called hyperinsulinemic hypoglycemia. So the abbreviation is PPHH. But getting back to Joanne's question, what's so interesting about it is there are studies that predict who's going to have that after gastric bypass surgery, because it used to be thought that the gastric bypass surgery caused it. But more in-depth research showed that it pre-exists, the gastric bypass surgery, and it is one of the causes of the obesity, one of the primary causes. People may not feel the low blood sugars when they're at a high body weight because the body adapts and forms something called insulin resistance, which keeps the blood sugar from dropping as much, but the problem's still there. Then after the surgery, same thing with if you went on an extreme diet, or even it's true, like even something like metformin without knowing you have this, it could trigger the recurrence of the low blood sugar episodes. So all I'm saying for Joanne is it's not the Zepbound causing it. And in my experience anyway, you have to go with what your doctor feels is right for you. Of course, I'm not giving medical advice. But the Zepbound is unlikely to be like causing it at all. But unfortunately, the Zepbound doesn't seem to be powerful enough to correct it either. But there are some things that you can do to correct it. The first step's do the mixed meal tolerance test. And if the insulin's high after eating, there's a great medicine that's used to just correct it. But as you're saying, Joanne, it's happening at night while you're asleep. And so, of course, you're not going to be able to correct that with some medicine, around your meals. And what's happening at night is our liver releases glucose like little mini meals. And so the glucose comes out, it looks on your CGM, the CGM is a continuous glucose meter, and it's reading your glucose all the time. And when you eat a meal, it shows your glucose going up or down. But the same thing happens while we're asleep, because our liver, while we're asleep and fasting, releases these little mini meals while we're asleep of glucose. And so the same thing can happen, unfortunately, if your system is like this, where in response to the glucose from your liver releasing, your insulin also can go and oversurge, causing a drop. So that's one possibility. And another would be that if you're not consuming enough to make it through the night, enough carbohydrates, that could also lead to a low blood sugar during the night. So first, make sure you've got enough carbohydrates, you're eating regularly, you have a bedtime snack. And then if it's still happening, it's likely the insulin problem, PPHH. And there are good treatments for it, though.
You mentioned a drug. What can you say what it is?
Well, I don't want to get too prescriptive because I'm worried, about that but I think, if Joanne's doctor does that test and has any question, they could always reach out to us and I could talk doctor to doctor and let them know what it is that we do. And it's a standard, it is something, if you look up PPHH and maybe medications that are used in that condition, but I just think it might be going too far to just talk about specific medications. But the Zepbound is a useful medicine to have in there too. So it's not, I don't think there'd be a benefit of reducing it or stopping it. But I think it may require something in addition. But start with a carbohydrate snack, or a balanced snack before bed, and see if that helps.
Great. All right. Thanks, Joanne. Next up, Paul from Madison, Wisconsin. One of the constant themes, he says, is that diets don't work, and that's great information to know. But then, what can someone do to improve their metabolism? Dr. Cooper is clearly doing great work for her patients, but that kind of comprehensive metabolic analysis and treatment is beyond what many or most people have access to. So Paul says, what should people at all points on the financial spectrum do to have the best metabolic health that they can have? I'm thinking of everyone from those who can't even afford to see a primary care physician to those with health insurance that doesn't cover weight management. Paul, that's a really good question because, Dr. Cooper, we have become so aware that access to care, financial means, good insurance, it's kind of a complicated web that determines the quality of care that you end up getting, right? And you have to really advocate for yourself in a lot of cases.
Yeah, you really do. But I guess when you have to look at the clues around you, do you have any other signs of metabolic dysfunction? What are the signs you have of the metabolic dysfunction? Do you have high triglyceride levels? Do you have high blood pressure? Do you have prediabetes? Is your what's called the FIB-4 score, which is based on some very inexpensive standard medical tests for liver fat, is that elevated? So look at these key health areas, not just the body weight and the number on the scale, and see if it really is indicating that you have like a high risk metabolic dysfunction, because the higher the risk, the more you've got to really get it treated. So that's one thing to think about. And as we've said, really the only things you can think of aside from treating it as a medical condition that you have to go see, even your PCP is fine, whoever's your primary care provider. The thing is, they don't have to be super knowledgeable necessarily. They just have to be willing to try something and to care enough to look at what's being done out there for treating metabolic dysfunction. And I think that if you have basic insurance and you have a primary care doctor and you can put together the dots, do I have signs of metabolic dysfunction? Do I have physical issues like triglycerides, as we said, blood pressure, cholesterol imbalances? And does that all point to metabolic dysfunction? And then bring that up to your doctor. What could we do about this? Besides a blood pressure medicine, a cholesterol medicine, you could say, would a GLP-1 med be appropriate? You could offer that. And primary care doctors can prescribe those. And some plans, they are covered. So don't assume it's not covered until you try. But if you don't have any health insurance, that's just not, I don't advise that. Unfortunately, I know it's getting really expensive and the premiums are supposed to be going up even more. So I don't know what to tell people about that, but I think it's risky to not have health insurance and a primary care doc, especially if you're financially strained, because if something were to come up, it could literally bankrupt you, and it could be diagnosed at such a late stage that there's irreversible damage. So I don't know what else to say, but I feel like we've covered some of the lifestyle strategies in our other earlier question, and those don't cost a lot to implement. I mean, even higher quality foods, people complain that they're more expensive, but not if you do some of your own cooking. But then I know that people don't have time because they're working, so maybe it is more expensive to cook your own food. But buying things in bulk and just trying to not eat out as much and eat real food, get your sleep, stress management, be physically active. Do all of those strategies because that's readily available. And as I said, they're not powerful enough to reverse obesity, but they do improve our metabolic health.
Yeah.
Right. Walking doesn't cost anything.
Sure. And yeah, that's a really good point. I love, Paul, that you raised this question because this is something that we all have to deal with. And I really think that we need to re-emphasize what you just said, Dr. Cooper. Find a care provider who is curious and interested in helping you address the reason for your obesity. If your doctor is dismissive of you and says, oh, you're just eating too much or you're not exercising enough. And Dr. Cooper, we get so many letters from viewers all over the world whose doctor has said you just need to cut back on your calories and exercise more. We're still getting those. So if your doctor is saying that and is dismissive of the cause of your obesity, find another doctor. Find a doctor who's curious about really helping you. So
And
anyway.
it is really, I got to say, it is really hard because most of us have been conditioned over the years to think of our doctor as this, oh, like they know everything, because that's how we put we put doctors on that pedestal. But sometimes you have to say, you know what? Screw you. You're not everything. Yes, you went to way more school than I did and you know a lot more things, but I know some stuff too. And I know that I can find somebody who's going to treat me like the way I want to be treated. And sometimes you need to give yourself a little bit more credit than you give yourself. And you need to find somebody who's going to treat you the way you want to be treated and actually listen to you.
All right, Paul, thanks for that. Now, Andre, whoops, I messed up because we
No,
haven't.
I'm Andrea, but this next letter is from Andrea.
There we go.
And she's a little more fancy than me because I'm very basic. And I love that. I love when I meet an Andrea and I'm an Andrea and that we can go back and forth. And I always have fun with that with people, like an Andrea and I'm an Andrea. So,
And she's
hi,
from
Andrea.
Portland, Oregon. Maybe that's how
She's
they say
from
it.
Portland.
Portland.
So she knows what's going on. So she says, hi, Dr. Cooper, Andrea, and Mark. Thank you for such an amazing, life-changing podcast. Oh, you're welcome. Like Andrea, I've struggled with weight fluctuations my whole life. First diet at age 7. Oh, hello. And adult weight shifting between 227 and 150 pounds. Now 45, I finally realized I have metabolic dysfunction and disordered eating. I'm originally from Brazil, living in the U.S. And during a recent visit, my endocrinologist prescribed Mounjaro for weight loss. No Zepbound available there. My BMI was 30 at 209 pounds, 5'9". And despite playing 10 plus hours of tennis a week and trying intermittent fasting, I just couldn't lose more weight. I'm learning to fuel my workouts better now. After years of dieting, I'm still working to overcome a fear of eating. Oh, so many people. After 10 weeks on Mounjaro, I've lost about 18 pounds. Oh, good. And feel better than I have in years, even with perimenopause affecting my sleep. Food noise disappeared a few hours after starting and hasn't returned. Can you explain what causes food noise and how tirzepatide helps? My hunger signals remain, but the constant food noise is gone. Thank you so much for all you do. Gratefully, Andrea.
Ah, Andrea, that's such a great message, and it's so nice to like hear about that food noise, to have a chance to talk about it, because it's something that people talk a lot about these days. But and just to clarify for listeners, the Mounjaro and Zepbound are the same drug. It's just labeled differently and marketed differently. Mounjaro for diabetes, Zepbound for obesity, but they're identical. The liquid inside is identical, so they're interchangeable. But so, Andrea, what's interesting is within hours of taking this drug, you notice that change. That tells you right there, that is a biologic issue. That is not psychological, right? So this is why I'm kind of frustrated with the diagnosis binge eating disorder and stuff, and some of these things, because they look at it as a psychological issue, that people are, constantly hungry and occupied by food and can eat huge amounts. not recognizing that that's a biologic drivers that are doing that. It's creating emotional problems because it's stressful. But if within hours of taking a medicine, there's no food noise, that was a biologic thing that the medicine changed. So that wasn't a psychological, it's not a psychological medicine. So anyway, just to kind of clarify that, but we have satiety receptors in our brain that help us recognize the food that we're eating. And a lot of metabolic dysfunction involves obstruction of those satiety receptors or diminished input to those by other chemical signals. And so what the tirzepatide does is it reestablishes the communication between the gut and the brain so that the receptors in the brain that are these satiety receptors, which are called MC3 receptors and MC4 receptors, melanocortin, that stands for, those receptors regulate to a large extent our satiety. And what we mean by that is how our brain senses the food that we're eating as we're eating it. So what's great is you still have your hunger. Hunger is not the same, actually. So you're still experiencing hunger, which is great. But then as you're eating, your brain is recognizing that food you're eating with the help of the tirzepatide, which is kind of sending a signal to the brain, hey, see the food. It's kind of unblinding the brain to that food supply. And that's establishing a good connection at the receptors that recognize that. And they're sending a signal back to the body, oh, okay, we're satisfied. So, and then usually that is what's responsible for, feeling like you don't need any more food or you're not really interested in food until it's the next time to eat, which is usually a few hours later. And that's normal. And that's what people without metabolic dysfunction experience all day long, every day. Naturally. Normally. Yeah. And so I hope that helps kind of explain it. And I'm just so thrilled that you still have your hunger. And that's great, because you should be able to just stay on a consistent eating schedule and feel satisfied and kind of experience what people without metabolic dysfunction experience and take for granted all the time.
Yeah. These drugs are just really amazing, aren't they, Dr. Cooper? And, as we've talked about, we're just beginning to understand, that recent episode with Dr. Evan Nadler talking about we're just beginning to understand, and in many cases don't understand, how these GLP-1s globally impact in such a positive way the human body. So that's good stuff. Great question, Andrea. All right, final question is from Kendra in Berkeley, California. And I'm going to need some help, Dr. Cooper, with some acronyms that she mentions here.
Okay.
As someone new to GLP-1s who struggled with weight my entire life, the podcast has been mind-blowing. I'm confused about Dr. Cooper's advice to not restrict calories. Most practitioners seem to recommend eating your TDEE. What's that?
Total daily energy expenditure.
Okay. So most practitioners seem to recommend eating your TDEE minus 500 calories on GLP-1s. That's what people in the Surmount studies ate. I'll let you address that in just a sec. But as we all know, she says diets don't work and cause the metabolism to slow. Should we be eating our full TDEE calories and account for exercise too if we're doing that? Or should we be doing moderate restriction? And if we shouldn't be restricting, why are so many people losing weight and improving their metabolisms at a 500 calorie deficit on GLP-1s? I know if you address the topic to some degree, but I'd love to hear Dr. Cooper be much more straightforward about caloric intake. I also think it would be very helpful to address this in an episode if we shouldn't be restricting, because pretty much everyone on the various online forums is restricting. So, Kendra, we've touched on this recently, but this is such a great question, Dr. Cooper, to address again.
Yes, thank you so much, Kendra. And we did touch on this recently because we are hearing so much of this kind of questioning. And the Surmount study or trials that you're referring to are the ones, the drug trials, basically. And that's what we've talked about before, is all of the drug trials have involved these calorie deficits. So it's understandable why people think that's kind of what you should be doing, is what they did in the drug trials. But what we need to pay attention to is the drug trials are fairly short term in the context of someone who's lived with lifelong obesity that's in multi-year treatment process. The drug trials kind of are of limited utility for practitioners because they don't provide as much information. In fact, we don't really know very much about those study participants because with drug trials, we're looking more at their response to a treatment strategy. So that's a popular way to use the GLP-1s, is to use them on a calorie restricted diet. And the typical advice that's been going around for decades is to subtract 500 calories from your daily expenditure. One thing that's flawed about it is no one's measuring their daily expenditure. I mean, like these watches and things like that don't give you accurate numbers. You'd have to actually have your be in a metabolic chamber and measure 24 hours what your true expenditure is to really know what your TDEE is. So that's a kind of an artificial number to start with. But what we're trying to say is that the diets that people do, like the 500 calorie deficit type thing, the low carbs, the fasting, whatever, those do slow the metabolic rate down. And that's been well established that they do. People kind of diminish the importance of that and they gloss over it saying, well, that's not really that important. That's not really what's going to cause weight gain in the future. But I have to argue with that because when they say that, they're saying that the reason it won't cause weight gain in the future is because people could just stay on a lower calorie to adapt to that. They could just exercise more and override the influence of what's called metabolic adaptation to diets by just eating less and exercising more the rest of their life. So anyway, I personally and my patients don't see that as a reasonable solution. And so even though the studies have not been done, is what we've been kind of emphasizing on some of our podcasts lately to remind people, they have not done the studies without the calorie deficit in there. So they just haven't been done. And so how do we know they don't work? And how do we know that the calorie deficit in there isn't going to cause problems later after multi-year treatment when we're trying to see a strong enough metabolic situation where a person can just be eating normally and exercising normally without worrying about their calorie intake and potentially even tapering the medication doses somewhat. So we don't know that information. So what I go by is what I have seen for years. And, as we said earlier, where I started was I was measuring everything and I saw that it doesn't work long-term with this restriction. And so my idea is anytime you're introducing that restriction, you're opening the door to what's called metabolic adaptation, a slowing of the metabolic system. Why would you want to do that? If your whole goal is to strengthen the metabolic system, why would we want to introduce something that's been proven scientifically that slows the metabolic system down? It doesn't make sense to me. And in the slowing of the metabolic system due to diets, one of the hormones that has been proven to be affected is GLP-1. So our own body's GLP-1 gets weaker when we restrict our calories. Our own body's GIP gets weaker when we restrict our calories. Just like our leptin gets weaker, all the beneficial hormones of our metabolism get weaker over time. So why, as practitioners and physicians, would we want to tell a patient of ours to do something that we know will weaken their metabolism at the same time that we're prescribing a drug to substitute for a hormone that diet is weakening? I mean, to me, it's such crazy... It doesn't make logical sense to me, and that's why I push back against it, and I have for the past 25 years. Our thousands of patients have done just great without doing this restriction business. So I think that it's like as much a mindset as what you're physically doing. It's like you want to have a mindset that you're not restricting that you're not restricting your calories. And one of my patients I kind of got upset with, sorry if you're listening, but I won't say any names, but the other day, because they were like, well, I do this, I don't, always, have this meal, or I don't always have this snack. And I was like, well, why? And they said, well, it's not intentional. I'm not making a choice not to have it. I'm just not hungry or something. And I said, well, that means you're not making a choice to have it. Like, I mean, we need to make a choice to fuel. Make the choice to fuel, and so that's replacing these choices to not fuel or to fuel less. And I think so. It's not about counting your calories or figuring out what level of deficit you should be in or what level of TDEE, because you don't even know what those numbers are. Honestly, you've not been tested, and we're all different. We're not equations. So it's more making a choice to fuel your body, whether you're hungry or not. Like, you got to eat your meals and have the snacks in between so that it's not too long between them, so that your body starts to go into that defensive mode. It's almost like defensive eating is basically what we tell our patients to do. Eat defensively.
Wow.
To prevent that door from cracking open that allows the metabolic adaptation to set in. And by doing that strategy, I can tell you, I wouldn't have continued to do it for 20 years if it wasn't working. That first 5 years when I was trying the other stuff with patients, I knew right away that was not the answer. After 5 years, I was like, I've got to stop right away. And I will never prescribe a diet to a person again, just because that's doing harm. And then the next 20 years of not doing it, it's been just so rewarding for everybody. And so I wouldn't have continued to do it if it wasn't showing such positivity. So, but I'll tell you one little caveat is that when you have had a long history of dieting and you're trying to go to like normal eating, your metabolism can become really unstable in that shift. And that requires pharmacologic treatment and oversight and medical oversight to stabilize stuff. When I say unstable, I mean like glucose and insulin levels can start acting up very strangely. So if you don't have that oversight, doing gradual changes probably does make more sense. Gradually adjusting, gradually over a period of like a month or so, getting to normal, and with the assistance of a dietitian.
And, if you're counting calories and saying, thinking that you can trick your body by reducing by 500 calories and thinking that your body will say, oh, well, we'll just burn fat then if we don't have these calories. Exactly opposite is true.
Exactly.
When the brain and the body feel secure, that's when the body starts burning fat, right, Dr. Cooper?
Yeah, it's so true, because if you reduce those calories, this is, what we used to do years ago with our gas exchange, see that if you eat X amount less, your metabolic rate starts slowing down by that amount. And if you put that fuel back in, it starts speeding back up. So we have a big amount of like flexibility with our metabolic rate. It's huge, plus or minus hundreds of calories. And so I try to get people to eat at the top of that, to keep their metabolism burning at that higher rate.
Yep.
And we'll get a lot of pushback because I don't have scientific research to show you this. I have clinical data, though. I have lots of clinical data. And we do, probably over 1,000. We have probably over maybe close to 1,500 patients, with hundreds with over 10 years of data. And so we do have that, and we do collect, as you and Andrea know, we collect your forms at every appointment that shows your eating patterns and the food groups that you're eating, the frequency you're eating, all of that data we've been collecting for years. And we can analyze that too with our whole patient population. They are not cutting out carbs. They're not, focused on cutting out foods. We are trying to get healthy eating, as we always talk about, because it's good for our health. But we're not emphasizing, we're emphasizing that choice to fuel, making the choice to fuel your body and to make efforts to do that instead of the opposite.
All right. Well, we're at time, I think, team. Any takeaways, Andrea, for you from this mailbag episode?
keep eating.
It
And
sounds basic, but you've talked about
it's
it, Andrea.
look,
The
it's not
freedom
it's not as
that
easy
comes.
as it sounds
Yeah.
sometimes. It's crazy. Um, you know, sometimes with the drugs, you do forget sometimes, because you're sort of going on with your day and you're like, oh my God, snack time. Oh, and you do have to remember, but it's worth it. It really is.
Wow. Well, some really good questions this week, and thanks to everybody who wrote in. You can find us at fatsciencepodcast.com. All of our resources are there. You can find us on social media. Just search for Fat Science Podcast on social and start following us there. We'd appreciate the follows and the interactions from all of you from all over the world. Thanks so much for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.